Welcome to our presentation, a panel discussion with experts on using ketogenic therapy to treat serious mental illness.
Our learning objectives for today include to describe the relationship between metabolic dysfunction and common mental illnesses, to explain the modified Delphi methodology that was used to examine the opinions of ketogenic metabolic therapy from mental health experts, to identify 10 recommendations outlining when, how, and for whom ketogenic metabolic therapy can be used in psychiatric care, and to discover how the treatments of metabolic dysfunction with lifestyle changes may offer clinical benefits.
For those of you who are new to us, my name is Elizabeth Errico, and I'm the Executive Director and founder of the Children's Mental Health Resource Center. We are a nonprofit organization, and our mission is to provide guidance and resources for early identification and management of mood disorders, bipolar disorder, and its newly identified and recognized phenotype, thermoregulatory sleep dysregulation disorder, which is also more commonly known as fear of harm, or FOH. In order to fulfill this mission, we work with both families as well as providers in order to shorten the documented 10-year treatment onset delay that most children face when they live with mental health challenges. Because of this enormous treatment onset delay, we are constantly exploring and sharing with families and providers safe, non medicinal interventions that can be used at home to help treat the symptoms that are not necessarily being treated in any other context. To do this, we work with families and practitioners. We have research based information that guides the services and programs that we offer to support early, effective treatment access. Ketogenic therapy has been shown to be safe in children for over 100 years from its use in treating epilepsy and treatment-resistant seizures. And in the last 10 to 15 years, the burgeoning field of research into ketogenic therapy for mental health has allowed us to begin to explore the use of ketogenic therapy in children for treatment of mental health disorders. So I'm very excited that tonight I am able to present with you a new paper that was published less than a month ago on February 23rd, 2026 in the journal Frontiers in Nutrition. This paper is called Awareness and Best Practices in Using Ketogenic Therapy to Treat Serious Mental Illness, a Modified Delphi Consensus. And so with us today to discuss this paper are its authors, Dr. Georgia Eid, Dr. Matthew Bernstein, Dr. Lori Calabrese, Nicole Laurent, Dr. Chris Palmer, Beth Zupek-Kania, and Dr. Shivani Sethi will be joining us later. So now I would like to stop this screen share and invite them all to join me on screen, where we are going to be able to talk about this really remarkable paper. So thank you all for being here with us tonight. To get started, I'd like to give you each an opportunity to just very briefly introduce yourself and let us know how long you've been doing this incredibly important work. I'm just going to go around my screen because there are so many of us, and start with you, Chris, Dr. Palmer.
Hi, everybody. I'm Chris Palmer. I am a psychiatrist at McLean Hospital and Harvard Medical School. I'm the director of the Metabolic and Mental Health program there and lots of other things. And I have been doing this work I've been using ketogenic diets in mental health patients for about 25 years.
Wonderful. Thank you. Georgia, Dr. Eid.
Hi, thanks, Elizabeth. So I'm Georgia Eid. I'm a psychiatrist based in Massachusetts, using nutrition and metabolic principles in my work for about 15 years now. And I'm really excited to be here on the panel with everybody.
Welcome. Nicole.
Yeah. My name's Nicole Laurent. I'm a licensed mental health counselor in Washington State. And I've been focusing on, as Georgia says, metabolic principles for mental health for 8 years now.
Wonderful. Uh, Matt, Dr. Bernstein.
Hi, everyone. Matt Bernstein, also Massachusetts. And I've been doing clinical psychiatry for about 25 years, more of a newbie to the metabolic principles, more like about 5 years, but incredibly impressed by how powerful it is. And I run a program called Accord where we're doing it as an immersive treatment, and I'm seeing some incredible results. So very glad to be here to talk with everyone.
Wonderful. Lori, Dr. Calabrese.
Hi, thank you. I'm Lori Calabrese, and I'm the founder of Touchpoints 180 in Connecticut, where I have been using metabolic treatments for this last 7 to 8 years, 6, 7, 8 years in my practice, and very excited to be here as part of this panel and to discuss the emerging work.
Thank you for being here. And last but not least, Beth.
Hi, I'm Beth Zupek-Kania. I'm a registered dietitian and nutritionist, and I have worked with ketogenic therapies for over 35 years now. For the first 20 years, just with epilepsy in hospitals. And then I branched out into private practice so that I could work with people with other conditions. And I'm very excited to be here.
Well, thank you all for being here. I want to start by sort of digging into why metabolic therapy for mental illness. The paper opens by noting that sort of the pharmaceutical interventions and the psychotropic medications that new avenues here have basically stalled. Can you sort of describe the treatment gap that motivated this consensus effort that you all spearheaded? I'm going to just jump in here and say, Georgia, why don't you get us started?
Well, I think it's probably no secret to anyone who's been through mental health treatment themselves or who practices in this field is that the treatments that we have, the conventional treatments that we have been relying on for so many decades, they unfortunately they largely fail most people. They really don't bring enough relief to most people, and the relief that they do bring comes with significant side effects in terms of lost years of life, lost quality of life, often great financial burden, and often disability. And so we really do need new tools in the toolbox. And I think that that's something that we can all agree on, whether we already practice this way or not. That what we have at our disposal currently, until this came along, was very limited, and often kind of heartbreaking and frustrating, to implement. No matter how hard you tried, most of your patients just didn't get that much better. So it's wonderful to have new options to offer people as that can be added to existing therapies if they're working partially or even fairly well. These therapies, because they improve brain health and metabolic health, it makes sense to consider them in almost every case as at least an adjunct to existing care.
So what does treatment resistant look like in practice when we're talking about patients with depression or bipolar or schizophrenia?
Are you asking me again, or
I'm asking the group. So anyone should feel free to jump in here at any point if you think, oh, I want to take this question. So go ahead, Chris.
Yeah. So that's actually been the focus of my clinical work for the 30 years I've been at McLean Hospital, is treatment-resistant mental disorders. And so I ran a psychopharmacology consultation service. I've had plenty of patients that I have recommended electroconvulsive therapy to, transcranial magnetic stimulation, ketamine, all sorts of things. I've had a lot of patients, more than I can count, who've come to me they've already seen, 4+ other psychiatrists, therapists. Some of them have tried 30+ medications. And they've already tried, electroconvulsive therapy. They've been hospitalized multiple times. And, I just want to say that although those treatments, they really can work for some people. So let's not be, I don't want to be anti-psychiatry, and I'm not anti-psychiatry. And I still prescribe those treatments when appropriate because they really actually do work for some people and they can genuinely save people's lives. Um, uh, they fail to work for far too many people. And there are millions and millions of people who are doing those things and not getting better. And if anything, just experiencing side effects from the medications and really kind of living second class lives. And many of them are told, well, this is what it is to be schizophrenic. You just have to accept that this is your diagnosis and this is your lot in life, or this is what it's like to have chronic depression or bipolar disorder or even sometimes personality disorders. That this is just what it's like, and you just have to kind of suck it up and accept this. And so I just want to say it is like beyond exhilarating to have a novel treatment. It does not work for everyone, but to have a novel treatment that works for some of these beaten down, hopeless people who have really been told that we don't have anything more to offer you. It's great to be able to offer them something else, and it is still to this day dumbfounding when I see it work in amazing kind of remission style ways.
Well, we definitely see that desperation and that hopelessness in families quite frequently, especially around medications, because there seems within the pediatric population to sort of be a default that the only thing that will be possible to give as a treatment for some of these serious mood disorders are going to be antipsychotic medications, which have really significant side effect profiles, especially metabolically. So, how do you all see the burden of those side effects from antipsychotic and other psychotropic medications?
I think I
Lori.
see the burden. Yeah, I think I see the burden as incredibly pervasive, not just across ages, but across diagnoses and over time. And so, as Chris was talking, I was thinking, oh gosh, what treatment resistance is not the person who's treatment resistant, but the person who's trying. Because what I see is people who try and try and try and try and try one medicine after another, one treatment after another. And the kind of burden of side effects ranges from the metabolic side effects of increased hunger, weight gain, appetite dysregulation, insulin signaling and insulin resistance, to the real heaviness of cognitive dysfunction, slowed speech, slurred speech, slowed thinking, extrapyramidal stiffness, right? Restlessness, sleep disturbance, excessive sleepiness. It just affects every part of a person's life. And sometimes, not all at the same time. Sometimes one thing starts and then another thing develops, and then the ultimate worry that patients have that we see now is the emergence of tardive dyskinesia. We were told, we thought, oh, all of these new medicines, they're so much better than the old medicines that we have. And truly, the emergence of tardive dyskinesia has become catastrophic for young people and middle-aged people on low doses now of medicines, not the high doses over years.
Mm.
I just wanted to add too, I mean, Lori did a great job summarizing the effects, but just to double click on antipsychotic medication in particular, when we block people's dopamine receptors, what are we doing to them in terms of their ability to experience pleasure and motivation? Dopamine is an incredibly important neurotransmitter for allowing people to know what's important to them and what they need to pay attention to, what's going to motivate them to get up and have a drive to get something done. When we block that, we're really removing that motivation system from someone's existence, and that is incredibly disabling to people. And so I just want to just double click on that point. And long-term effects, metabolic effects, and all the other neurological effects are there too. But I see that sapping of motivation as being really central to the issue that we're causing with long-term antipsychotic medication for many people. Again, not everyone, as Chris said. For some people, these can work really well and people can function, but it's very, very common to see that in my practice.
I want to, if I can add one more
Yeah.
thing. I know you don't want to dive too deeply, but I want to add a couple things. One is that because I know compliance is going to come up at some point. That's one of the biggest pieces of feedback I hear about ketogenic diet. Who can possibly do that? Well, it's really important to also look at the compliance rates with antipsychotic medications because a lot of people with schizophrenia and bipolar disorder and other diagnoses will not take them because they make them feel crappy and they will not take them over and over again. So much so that there are people with schizophrenia who would rather be homeless than be compliant with treatment because the treatment makes them feel awful or because the treatment simply doesn't work. And so I think it's really important to take that into account as well.
Thank you for bringing that up. Nicole, yeah, I was going to ask what you wanted to add. I saw you nodding.
Yeah, um, there are a couple things. So I want to speak to what Matt was saying as someone who's been a psychotherapist for 18 years. The last 8 years, I've been focusing on ketogenic transitions. But you know, when I was in graduate school a long time ago, we were told that medications would help people do better psychotherapy, that medications were somehow going to reduce symptoms enough that they would be able to do better psychiatric or psychology work with us. And my experience over many, many years was that was not the case at all. And so that's an important thing to kind of understand. I feel like that promise just really fell through. And you can really truly try to do really, really good psychotherapy work with individuals. But if they are, for example, like Matt was saying, they're unmotivated, right? I mean, what happens when we give these medications and they're unmotivated to do all the things we're telling them to do? They internalize that as shame. It's unreasonable. It's unfair. So that was just something I wanted to kind of point out that promise did not come through, at least in my therapy room, and I suspect other people's. And also, we put these people on these medications. We tell them to do these things, with great cognitive impairment, and I think that that's unfair to them for sure. And then the other thing I was going to say is I do professional training for psychotherapists, and one of the things that we talk about is we go through the myths of ketogenic therapy, and one of them is that it is unsustainable, as Chris is saying. And one of the things I point out is even though there's such poor compliance with psychiatric medications and antipsychotics in particular, we would never use that term that it was unsustainable. Right. We would never. So the language that we use in this space about these medications in comparison to ketogenic metabolic therapy is just really interesting to me. So that's all I wanted to add.
Yeah, and I want to just speak to that briefly as well, because in our work with families, there is a real concern at the very beginning. Oh no, this is overwhelming. Oh, how are we going to make these enormous changes to our lifestyle to accommodate the therapy, and how are we going to sustain it? But when the therapy starts to work and be effective, the concerns around sustainability start to drop away because they realize what a small cost it is in terms of imposition to be able to reap those kinds of benefits. So it's just to some degree that the proof is in the pudding, if you'll forgive the potential pun. But I want to dig in a little bit into this idea of metabolic dysfunction being correlated with mental illness in the first place, which may connect to why these therapies, we may discover this is why this therapy is effective. So, for example, people with schizophrenia are 3 times more likely to have insulin resistance. How does this shift towards thinking about treatment, metabolically based treatment, shift the way we think about psychiatric illnesses in the first place?
Well, right.
Yeah.
We have to start thinking about, say, what we were trained, all of us in our professional training, to think of these problems, all of these mental illnesses, as chemical imbalances. From a biological standpoint, the biology behind it was something to do about chemical imbalances. Not that we can test for these chemical imbalances in the office, not that we can tell you whether or not you have one or which kinds you have. But that's how we were trained, and we were trained to treat them with medications by, kind of choosing randomly without really any guidance, trying to find a medicine that might help you, and very much trial and error approach. And so now that we understand that there are really strong correlations between poor metabolic health and poor mental health, and we even have some almost causal level evidence coming out in recent years in terms of, for example, with Dr. Cynthia Calkin's work out of Dalhousie University with people with bipolar depression, she found that if she could reverse their insulin resistance with a medication, metformin, if she could reverse their insulin resistance, their bipolar depression improved dramatically. And so that suggests that it's not just a coincidence that people with poor metabolic health are much more likely to have mental health problems and vice versa. But it also suggests that insulin resistance is playing a direct role, contributing to the severity or the progression of the illness, if not being a root cause of it. So we have to stop thinking about why are so many people suffering in the first place, and how much of this might be due to living a lifestyle which is causing tremendous metabolic dysfunction.
Go ahead, Chris.
So, yeah, for people who don't know, I wrote a book called Brain Energy that really dove into this, and that was really the primary thesis of the book. And I want to just say that although a lot of people think about poor metabolic health as either being overweight or having insulin resistance or diabetes, metabolism is actually so much more complicated than that. And you can be a thin, young child and have no insulin resistance whatsoever, and you can have metabolic problems in your brain. And that can cause what we call psychiatric disorders, neuropsychiatric disorders. And that metabolic dysfunction is not at all only potentially caused by diet. It can be caused by an infection, an autoimmune condition. Genetics can influence it. And in fact, if you look at the list of, well, what all can influence metabolism, it comes back to something everybody already knows: biological, psychological, social, and I will throw in environmental factors all influence metabolism, brain metabolism. So trauma is a common, well understood cause of mental illness. Trauma impacts metabolism. People who have trauma young in life are more likely to develop a broad range of psychiatric disorders. That's not surprising to most people. People who have trauma in young life are also more likely to develop obesity, diabetes, cardiovascular disease, and die early deaths. So I think we just need a much more sophisticated, complicated, nuanced understanding of what is metabolism, what does metabolic mean, but that opens doors. It opens massive doors to a whole new way of understanding and treating mental illness. And I'll get off my high horse and shut up.
No, that was wonderful. I'm so glad this is being recorded. So I'm actually really glad that you brought up all of these different factors that go into our psychological health, our biological health, our metabolic health. Because one of the questions that we get asked very, very often, and I can see it in the chat, is about conditions like PANS and PANDAS, and what impact ketogenic therapy may have on some of those illnesses as well. Lori, I see you're poised to with a response here.
Maybe Matt and I will share a response to this one.
Yeah.
So there, we know both from preclinical models from animal studies and from human experience and from some of the early human work that we've done that there are incredibly complex gut-brain signaling circuits that run, and they run starting in the gut and starting sometimes with exposures to things that turn on a whole host of what we call inflammatory cytokines that find their way into the brain across the blood-brain barrier and that absolutely can turn on start-stop mechanisms involving glutamate and GABA and create OCD like overnight in an instant. How's that possible? What we haven't had, we've had the correlation for a couple decades. We haven't had the mechanism or the potential mechanisms until now to begin to look at that. And so it's really rewarding to think about impinging on that mechanism by saying, you know what, with OCD that won't stop, with recurrent OCD that flares, is there a way that we can decrease systemic inflammation? Oh, how? Well, by measuring it, first of all, and then by turning on one of the levers that can decrease the insulin signaling that drives that, and then perhaps reduce OCD. We've seen it. We've actually published it, and we've published clinical remission of associated autoimmune and inflammatory conditions like ulcerative colitis all at the same time, all in a very short period of time when it's happened, when those symptoms have been happening in a person's life for years. So lots of exciting emerging work there.
Yeah. Matt.
Yeah, I just wanted to add, I mean, Lori, that's a great summary of the science. I just want to add, my two of my sons, I have three kids, two of them had PANS about 9 years ago, and it was overnight mental health problems that didn't exist the day before. And it was very extreme, very severe. And it looked like classic OCD until you really looked further and saw that there were a lot of physical signs as well. And I just wish I knew then what I know now about how powerful the ketogenic diet would be for treating that kind of brain inflammation. And it would have been absolutely the first thing that I would have done. And just so for parents out there who are dealing with that condition, I would highly recommend thinking about this as a primary intervention before going down the road of IV or PO antibiotics and anti-inflammatories and all the other things that might be recommended, or all the functional medicine things, which we ended up doing. This could be a much simpler and more elegant solution to the problem.
Thank you for that. So I want to start talking now a little bit about the methodology that was used in the creation of this consensus. And so the study that you all did was a modified Delphi methodology to build consensus. For those who are unfamiliar with what that is, can you explain what this approach is and why it was chosen? Georgia, we'll start with you on this.
So the Delphi process has been around for quite some time, and it's a way for to generate consensus and guidance for a particular field where there isn't quite enough robust clinical experience, like a large amount of collective clinical experience, or enough randomized controlled trials and higher levels of evidence amassed yet to be able to guide the field. And so that was what decided, was to bring those of us together who have many years of experience studying these therapies and using these therapies in clinical practice, to bring all of us together and see what we could agree on when it came to, who are good candidates for ketogenic metabolic therapy. What do we see in our own work? How do you evaluate somebody to see whether they're a good candidate for the ketogenic diet? What kinds of cautions do you need to be aware of when you're implementing the ketogenic diet? What kinds of testing might you want to do? How do you guide the therapy? What do you want to look for in terms of benefits and risks? So nothing like this had ever been published before, because we'd all been essentially working pretty much independently. Those of us you see on the screen, we know each other, and we see each other frequently at conferences, and we belong to a lot of the same networks, but we really haven't worked together very much at all, here and there a little bit. So it was interesting to see how we gathered. This was all done virtually. We gathered with a third party facilitator, and and uh, uh, 33 statements were generated about ketogenic metabolic therapy that were all supposed to weigh in on. And then those statements that once we had consensus around those, we sent those out to a wider group of people outside of our circle, with knowledge and experience in ketogenic therapy, to see, how many of those other people would also agree on, just to see, okay, is there agreement around a lot of these statements, or are we seeing different things, or can we even generate a consensus? And I think that process was interesting to me, because I was genuinely surprised how much agreement there was between all of us, who were working on this paper together.
So how were the 33 consensus statements developed? There was a steering committee, right?
Right. And so the 33 statements were, they were suggested by the group, and then all of us kind of weighed in on them. And it's quite a while ago now that we did this, so I'm trying to remember exactly how we came up with these 33 statements. But and anybody else can chime in if they want to. But I believe that they were generated by all of us together, and they were suggested also by the facilitator of the group.
So with these 33 statements, there was consensus achieved on them above 75%, I believe, and some of them even reaching a 91% agreement. Was this level of agreement expected?
As I say, I was surprised at the level of agreement. So people can see it. And there was very, very high level agreement on all these statements. And so I really was surprised by that. Again, because we do work relatively independently, and there was some discussion around certain elements of these statements. But it really was, I thought, surprising and also very encouraging, because there are, I think, a lot of things that we can all say and agree upon about how to proceed with a ketogenic diet, when it makes sense, when you need to be more careful. And I think that has largely to do with the fact that we all have a lot of experience in this field. We've read deeply. Many of us have published in this field. We've studied these diets intensely and how they work, and we have a lot of clinical experience. And so, and there was also a researcher among us who's not a scientist, Dr. Ian Campbell, who's not here with us, who is one of the world's leading researchers in the field, who understands the biochemistry of this approach very well. So I think that it's very encouraging that there is, even though there isn't a lot of robust, large and randomized clinical trials in this area. We do have a tremendous amount of science to lean on, going back 100 plus years now in the field of epilepsy. And we also have a growing a body of clinical work that we can all, a lot of us have worked with, hundreds of patients. And so you do really get a feel for how to use these diets in clinical practice that I think will be very helpful to other clinicians who read the paper.
So I want to dive into what these 10 recommendations that you all settled on are. The first two, which really seem to reflect some of the things we've already talked about here, which is, that ketogenic metabolic therapy should be considered as adjunct therapy to first-line treatments for major depressive disorder, bipolar disorder, and schizophrenia, and that individuals with these conditions who decline, cannot access, or do not tolerate, or have not sufficiently benefited from these first-line treatments should also be considered for a trial of ketogenic metabolic therapy if they qualify. Now, I think we've already sort of addressed this issue in our introduction, but if there's anything anybody would like to add, one thing that Nicole, I've heard you talk about is using this as a transdiagnostic approach. So I'm wondering if you could jump in here and just share a little bit about that.
Yeah, absolutely. So, yes, Chris published, I think, with McDonald, is it recently on a transdiagnostic features of a ketogenic diet as a treatment modality, and it's being spoken about more and more in the research literature with that term. And I think that that makes sense when you look at the different DSM diagnoses and you look into the different factors of brain hypometabolism, neuroinflammation, oxidative stress, disruption of neurotransmitter systems. And if you look into those particular diagnoses, looking for those things, you find them. And so it makes sense that a ketogenic diet would be able to help address those four factors. And then there's, of course, many more coming out in the literature, neuroimmunological, endocrinology type factors. And so it really it's really, I know everybody wants like that perfect RCT with that one diagnosis to kind of show, but I think that that's really kind of holding us back. And I would even say ethically, as practitioners, us waiting for that perfect RCT with that perfect diagnosis to show that, I'm not so sure that's a great stance anymore. I think that there's a shift in the field that needs to move to these transdiagnostic paradigms of understanding mental illness. And so that's why we speak about it, or I write about it in that way.
Lori?
I love the word adjunctive. The very first statement said this should be considered as an adjunct therapy. And I go back to that word because I think as a physician and as all of us clinicians would agree, safety's first. And so when we're looking at someone, and when someone, of course, is looking at themselves, we're always balancing what do we need to do first and foremost to keep this person safe, get this person safe, acutely treat what need, or acutely offer help for what needs acute help, while if they're interested, if they're a candidate, if they would like this adjunctive treatment, we take the time to do this well. We take the time to introduce a ketogenic treatment in a very structured, lovely way that is personalized and amenable to the person that we're working with, right? So I'm high on the adjunctive word here.
Absolutely. Matt?
Well, just to add though, the second statement, I mean, I agree with Lori. If someone's already on a treatment, we're not going to pull that away in any rapid way. Of course, that would be dangerous, and we want to keep people safe. Yet I'm seeing people all the time that fit the second statement, people who cannot tolerate these medications, cannot benefit from them, will not take them. And as Chris pointed out, the track record of people taking antipsychotic medications and choosing to do so over long periods of time, it's very rare, actually. And so this also should be considered in those situations as well. Why not? We have someone who needs help. This could benefit from them, and it's incredibly safe. And so if they're willing to, do this, walk this path with us, this is an amazingly good option for those folks as well.
Yeah, and I'll add for parents in particular, there can be a lot of concern and fear around introducing psychiatric medications when their children are small, and being able to offer an adjunctive treatment that may be able to provide some relief from the symptoms that they're experiencing without all the risks that go along with those medications can be very appealing. Now, Chris, you already talked about the third recommendation here, that in the absence of observable signs of metabolic dysfunction should not preclude individuals from a trial of ketogenic metabolic therapy. Can you elaborate on that?
Yeah, it is. I'm gonna kind of repeat what I said before, but biological, psychological, social, environmental things can all disrupt brain metabolism that can sometimes be amenable to ketogenic therapy. So, the PANS panda situation is a clear example. Chronic Lyme, autoimmune disorders, they're all trauma. There are all sorts of things that can disrupt homeostasis in human metabolism. So that statement I will stand behind. There's a tremendous amount of complexity to what I just said, but that statement is unequivocal, and we have more than enough. It is not speculative. It is not emerging science. It has been around for well over a century. We have known this. This is well known. And anybody who doesn't know it is not a neuroscientist or doesn't understand the science of metabolism and biopsychosocial. So, so again, that's one of my biggest concerns is people confuse metabolic with overweight or diabetes. And therefore, if you're thin and have a mental illness, well, that's not metabolic because look how thin they are. And let's go all the way to the extreme. You can be underweight and have a disorder called anorexia nervosa, and you can have metabolic problems as a consequence. And this is really confusing for a lot of people, but let me make it simple. Why would that be? Because calories are actually being burned in your mitochondria to support metabolism. That is a prerequisite to healthy metabolism and essential nutrients, vitamins, other nutrients are key. And so people with anorexia nervosa who are way too thin, emaciated, can actually have a metabolic problem in their body and brain due to malnutrition and shockingly, ketogenic therapy, that restrictive diet called the ketogenic therapy can be life-changing for some people. And we've already got pilot data. Beth Zupek right here is one of the key researchers and authors on one of the pilot studies in that research. And we've got a new study that's probably going to come out soon and more research happening. And I can say clinically, I've seen nothing short of miracles in this area.
Beth, I really want to draw you in. You've been quiet up until now, but I'd love to hear you respond and also tie you into the next recommendation, which is that at minimum, the healthcare team should include a nutrition professional and a prescribing clinician trained in the safe implementation of ketogenic metabolic therapy.
Yeah, so we're the food therapists, and this whole field has been so wonderful to work in because there's been such great collaboration between psychiatrists, nutritionists, therapists like Nicole working together. Like everyone has realized this is a team effort, and we really can't provide this without that effort and provide it well because of such a lifestyle change. We're not just talking about what you eat. We talk about why you eat,
Mhm.
how you feel when you eat. If you have food insecurity, that affects your ability to do any kind of a special diet. And so we need this team of people to support this individual. And I worked with families for 20 years with epilepsy, and I've never seen such motivated families. That's why I stuck with this, because the results are amazing. And in epilepsy, at least 60% of children who go on a ketogenic therapy get these fabulous results. They may not be completely seizure symptom free, but they get such good results that they are able to, at some point, to start tapering down one of their medications. In fact, with epilepsy, this is not true for psychiatric disorders yet, but I just want to bring this up for epilepsy. There is a criteria that if a child has not achieved seizure control after trying at least two medications, it's known that trying another medication is not likely going to help them. So that's when the ketogenic diet becomes an option. And that's why we name it resistant epilepsy, treatment resistant epilepsy. It's resistant to at least two medications, or maybe the medication helped a little bit, but the child was sleepy all the time, or acting out. So they have to be medications that work, not just on the symptoms, but in improving behavior. So I just want to throw that in there because I think I see the same thing happening with psychiatry, is that these are treatment resistant. Medications aren't helping. Something else is going on. And why don't we address metabolism? Because medications don't fix metabolism. In fact, many of the psychiatric medications make metabolism issues worse. And that's also been studied. Chris and Georgia talk about, and Matt talk about that in all of their lectures. That's something that, is a setback. It's a setback to have medication that puts you at risk for metabolic syndrome, which can develop into diabetes, etc. So,
Well, I
Can
love
I,
hearing you say
can
that.
I,
Yeah,
I
go
was
ahead,
just going to
Chris.
say, can I just interject? I want to apologize to Dr. Calabrese because she also was one of the lead authors and experimenters on the anorexia trial. So I'm sorry that I did not give you the credit you are due.
Um, well, thank you for that. Beth, I want to underscore what you've said because I think four might actually be my favorite of all of the recommendations. That and number five, which is, prior to consideration, a thorough medical and psychiatric history should be taken to assess for absolute and relative contraindications. Because to us, when we work with children and families, the most important piece to even beginning to start the process of healing is that differential diagnosis, is that extensive history taking. It's really being able to understand when, how, what was going on when these symptoms first emerged, everything going back to the womb, if we can get that information in order to be able to put together a truly holistic picture of this patient as a person. And to do that kind of holistic treatment requires a holistic team. And I think back to my very early days as a mental health professional working in a partial hospital program where every single patient had a psychiatrist, a psychiatric nurse, a social worker, and a psychotherapist who worked as a team. And one of the greatest struggles we find, especially with children, is that there is no team when they are in outpatient treatment, that they're seeing one person or another. Those folks aren't communicating with one another, aren't creating that interaction, aren't and very often a psychiatrist is the very last person a child sees. They go through school counselors and occupational therapists and pediatrician long before a specialist is brought in. And so the idea that you are supporting the creation of an interdisciplinary team to provide structural support in all areas of treatment, I think is just absolutely fantastic. And I genuinely hope that more providers are willing to be part of that kind of teamwork for not only families with children, but families with adults, because mental illness impacts everyone in the family, everyone in the household. Beth, a question came in on the chat a little while ago in relation to talking about families and compliance, and was wondering if you could share a little bit about how you work with families to achieve compliance in difficult situations.
I think it's really important to sit down with the whole family for one of the first chats. It's usually my second chat, not my first one. The first one is answering questions about the lifestyle change and can we even figure out how to make this happen in our crazy household, but then getting the family together, surrounding that child, maybe grandma, maybe a neighbor, whoever is involved, and having a chat, because a lifestyle therapy can be sabotaged by a well-meaning person. It's usually a grandma. or grandpa. Um, but to have those people sit down in front of the screen, we're all working virtually, and get their questions answered and have them understand that this is a really old treatment and it can be super effective. And the more support there is, the more likely the child is going to do well and be able to stay on it. And what does support look like? It's about eating together and not eating certain things in front of that child. It's about helping prepare food. There's all kinds of things that we can talk about, splitting up, tasks that make this successful. I've had lots of relatives and especially grandparents say, "What could I do?" They can make a casserole that's keto or keto bread, some of these things that there's great recipes for, but take time to do that. And that is so helpful for a family, especially if it's a single parent in a family. So having that sit down chat, I find is, key. In fact, if I can't get this group together, I'm really concerned about being successful down the road with compliance.
That's a great point, and I think it dovetails nicely into recommendation 7, which is that the approach to achieving ketosis should be well formulated and tailored to the needs and preferences of the individual, with consideration for the long-term sustainability of dietary modifications. And Beth, you're really talking about the idea that very early on, there are certain signals that you get about whether or not this is going to be sustainable for this particular individual based on whether or not they are getting a ketogenic food plan that is tailored to their needs and preferences. Anybody want to comment on that recommendation in any more depth, or go back to something that we've already talked about? And
Just wanted to add in the
yeah.
importance of someone in the family or someone in the network cooking. And this is a thing that's really important. This is a therapy that involves, sustainably eating healthy food. And one cannot do that unless one can cook to some extent. You don't have to be amazing in the kitchen, but we need to be able to make our own food. We can never sustain this buying ketogenic meals or ketogenic packaged foods for a long period of time. We need to be able to feed ourselves. And so that's one of the things that I assess for right in the beginning. If someone can't cook, who near you, who can support you in the cooking until you learn how to cook? And that's one of the most important things that you're going to need to learn in order to do this intervention. And I just wanted to highlight that because I think it's very important and overlooked. It's not something we typically ask in medicine, how are your cooking skills? But it turns out to be one of the most important things in terms of long-term success.
Yeah, I'd like to underscore that as well, Matt, because in our programs, in our studies, part of what we do is we teach parents how to cook, and how to cook ketogenic meals, how to assess recipes to determine whether or not they're going to match ketogenic ratios, how to adjust them, make changes. And that can be extremely daunting. But being able to prepare safe, ketogenic meals at home can go very far. Now, I know that your program, you are teaching that as well.
Yeah, I mean, a lot of young people, we end up, helping a lot of people with serious mental illness. Many of them are young people, and it's just astounding how many people grow up these days having no idea how to cook. And so that's one of the first things that we're teaching people is how to start preparing food for themselves. Because if they're going to do this, if they start feeling good, the only way they're going to succeed when they go home is if they're going to be able to cook it or someone in the house can cook for them. So it's a really important factor. Yeah.
Yeah, and Beth, you talked about grandma and grandpa. We've found with some of the families that we work with that when grandma and grandpa are willing to test out those recipes and bring them over fully cooked, it can be a pretty great help to those parents who are working and trying to juggle this. So it really does take a village. So the next recommendation that I want to talk about is these actual measures of ketones and ketosis levels. So recommendation 8 is that the goal of ketogenic metabolic therapy is to achieve and sustain a degree of ketosis that could potentially lead to improvements in serious mood and or psychosis symptoms, and that ketones should be monitored regularly, preferably by measuring capillary blood levels of BHB. Now, many people in our audience may not know what BHB is, may not know what regular monitoring of BHB means. So can you all walk us through what that process looks like in practice? And anyone should feel free to jump in here.
I can address it because I teach it all the time.
Yeah.
So BHB stands for beta hydroxybutyrate, and you don't ever have to memorize that. BHB is much easier, and it just means the blood level of ketones. So we could measure ketones in the urine. That's how I did it for many, many years until we had the ability to check at home. And that's measuring a ketone, a blood, waste product called acetone. It's not super accurate, but for some people, that's still the measure that they use because it's the cheapest measure. It's easy. You're just peeing on a stick. So that's urine ketones, and we have the blood ketones. And there also are meters for checking exhaled breath from the lungs and trapping those ketones. And that's not quite as popular. It's not really used in research. So the blood is the what we call the gold standard. This is what everybody knows. This is what everyone uses in research. And it requires a simple drop of blood from a finger poke, which can be kind of scary to some people. But actually, I find kids a lot braver than adults when I'm teaching this. The prick is barely felt. And if you do it, the prick on the side of the finger where you don't have a lot of nerve endings, it's no more than just a pinch. So, in the beginning of starting a keto therapy, we want to get a handle on where your ketones are. So, you're testing them more regularly in the very beginning. And then once you get going, you kind of can guess where they are because they stabilize, especially if you're checking at the same time of day, which is what we advise. So they do stabilize, and uh, they can be very, very regular, which is typical. But if you get sick or if there's a flub up in the diet or something, they can be off. And then that's a good time to check as well. But the research that we've all been involved with and others is starting to show that you want at least this zero point 0.5 millimoles. Some people might need a little bit more than that. Some people might need over 1. So which do you pick? Well, you don't. You try for what's ketone level you end up with in the beginning. And if you're already seeing some improvement, you can just stay there. If you're seeing no improvement at all, that's when we say it's time to make an adjustment. We can get your ketones up a little bit higher, maybe with more physical activity, maybe with a little bit less carbohydrate and a little bit more fat. So those are the, metabolic changes that we can implement to make ketones a little bit higher. And then you might see some better results. At any rate, I know we're going to talk about this sometime because it's super important to talk about when you're on this new lifestyle change. When are things going to get better? Is it going to be a week or is it going to be 2 weeks? And I'm here to tell you it might take 4 months. So
Mhm.
that's a while, but typically you have some kind of improvement within those 4 months telling you to hang in there. This is already better. You're already sleeping better. You are connecting with people better. Some little hints that make you say, I think this is better than what we did before or what we saw before. Let's keep going.
Beth, you eloquently got us through recommendations 8, 9, and 10.
Oh,
But
sorry.
Nicole, go ahead. You wanted to add something, and then Lori.
Yeah, I just wanted to add that sometimes the people around you notice differences before you do. They'll notice you're finding words a little bit easier. They'll notice you're seem to be going to bed at a regular time. They'll notice these different things often before you do. Family members or spouses do. And so that's another thing that can kind of be helpful and Beth is right. It's really important to kind of point those out as wins along the way, because the kind of the way we think about whether a treatment works or not is whether symptoms stop, right? Like a medication works if it squashes my symptoms or it makes them stop. That's how it works. But I learned from Beth that in the epilepsy world, correct me if I get any of this wrong, Beth. I learned from Beth that in the epilepsy world, when they start people on ketogenic diets, it takes on average 3.2 months for them to get seizure control. And during those 3.2 months, they still might be having seizures, right? But they might be less intense, less frequent, less prodromal phase, period. And we don't have, the studies, but I kind of see that in people with mental illness using ketogenic diets. And so that is something I think that's really important, is that your algorithm for determining whether this is an effective treatment or helping kind of has to change a little bit away from a pure psychopharmacology model, because you're in essence, I suspect, healing a brain, and that might be a little bit messier than the algorithm that you're thinking about whether something works or not.
Lori, did you want to add something to that?
I think just a quick add-on, because I want to just emphasize that things get better differentially according to the kind of symptom it is, even across people. And that's a complicated way of saying, for almost every person, their journey towards improvement is a little bit different than the next person. Someone might instantaneously begin to notice decreased anxiety while somebody else is struggling with sleep. And so I think what's really been important for the people that we work with is to identify for them what they want to see get better. Not just the symptoms, not just the rating scales, but the actual other signals that tell them that they're better. And often we're looking for ways that they know that they're more resilient. How much less often they are arguing with their husband. How much easier they're able to take a stressor. And so we're looking for not just sort of the decrease in problems, but the improvement in resilience, flourishing, creativity, clarity of thinking, the ability to take on more. And that's the narrative part that makes this work so beautiful to follow along closely with.
Absolutely. I'd say with parents and children, oftentimes one of the first things we hear about is the parents sort of bracing themselves for what they have learned is going to be a triggering event resulting in symptoms, and then it doesn't happen. And so does that mean that the child is fully stable and has had all of their symptoms removed? No, but it means that there's less stress, there's less conflict, there's less difficulty in the home, and there's an improved quality of life. Matt?
Yeah, I just wanted to add in, patience is really important. We're talking about waiting for improvements and seeing the subtle signs, which is all true. But also what I tell people is that, you start to see these improvements. It's not like at 4 months you get all the improvement. That's just the beginning. Month 6 is better than month 4, and month 12 is way better than month 6. The longer these people do this, the longer I do it, the better we feel. There's a continuous healing process that goes on that just sort of iterates on itself. And, so more good things to come is a really important theme to keep emphasizing, I think.
And I would
and
also
go
add
ahead,
just
Georgia.
very quickly that the opposite can also be true. I mean, it's very common, or it's not uncommon and I just heard it. I just consulted with a young man the other day, 33-year-old man. He's tried the ketogenic diet several times before he consulted with me, and every time he tries it, within 3 days, he notices tremendous benefit. And he has bipolar disorder, substance use, and all kinds of other things. But I hear that fairly often, and I can and so even if I'm agreeing with everybody else here that even if complete or really major changes in fundamental symptoms may take longer, it's often obvious that something is improving fairly early. Often within the first week, something is shifting for the better. And I can often tell when I'm meeting with somebody for the second time during the second week, their tone of voice, the way they hold themselves, the way what we talk about. There's just a shift in tone, I think, that's especially noticeable. And so I think that even if the symptoms aren't gone, something is getting better. Sometimes there's a period, a week or two, where people are worse before they get better. That can certainly happen, and there's a lot of information that all of us have talked about around this. So there can be a roughening period at first, but for many people, it's things start to get better relatively quickly, and that motivates people to keep going to see, okay, what more might be possible.
So I want to just take a moment to welcome Dr. Shabani Sethi, also co-author on the paper, who was able to join us. Thank you for being here. Feel free to jump in at any point. But I want to give you just a second to introduce yourself to our audience. Just briefly say who you are and what brought you to working in metabolic psychiatry.
Thank you, Elizabeth, for the introduction. Hi, everyone. I'm currently in Florence, Italy. I just spoke today at the Schizophrenia Research Conference, and glad to be able to join you guys, even though at the tail end, glad to be here. My background is in obesity medicine and psychiatry. I started the Stanford Metabolic Psychiatry Clinical and Research Program back in 2015. I did a early pilot trial that was published in 2024, looking at ketogenic diets in both schizophrenia and bipolar illness. And we're kicking off with a randomized controlled trial, looking at a lot of other mechanistic things this month. And yeah, I'm happy to chime in. So far from what I heard, I agree that there's variability in timeline for people. And we can talk data and scales all day long at research conferences, but at the end of the day, when patients have stories to tell and experiences that really go beyond those scales, the qualitative feedback that patients give is really meaningful, and that's definitely why I do it. So congratulations, everyone here, because everyone here is working towards treating patients and doing research, and you got a great panel audience of 120 people. So glad to be here.
Thanks, Shabani. And that's a great segue actually into, we have another researcher and author in our audience who has added a chat, Dr. David Miklowitz from UCLA. And he's observed that when the patient is a teenager, they may feel stigmatized by being on a special diet in social situations, or they may feel isolated during family events involving large meals. And when they have to explain to their peers, whoops, I just lost his comment in here. When they have to explain to their peers, these are real world challenges that folks face, and researchers in their studies, clinicians in their private practices, they encounter these kinds of real life social challenges to being able to stay on plan. And so how do we as providers address that with families and patients when they're thinking, well, yeah, great, I'm seeing benefits, but this is also really making me feel different. Yeah, go ahead, Nicole.
Well, I know Beth has lots of good ideas for this, but I point out to people that you can make choices depending on different situations, but you don't generally, like, there seems to be a little bit of a feeling that if I go out with the ladies and go out to dinner, I have to explain why I'm not getting the pizza, right? Or I have to explain why I'm not getting this appetizer or that. And really often that is an imagined pressure that doesn't truly actually exist in any way, shape, or form. And quite frankly, not all of our relationships are safe and wonderful relationships or supportive relationships where we really would want to go into deep detail because they're not going to reflect back that they get it in some way, or they're going to have some kind of bias in some way about whether this is a good idea or not. And it's okay to not have to give the full story about why you're not choosing that particular appetizer. You really can just choose a different one or say that looks good on the menu. Now, and then of course, like with family and stuff like that, again, those same kind of relationships exist in families where you just maybe don't want to go into a big thing about why you're not having the mashed potatoes or whatever. Or you can say something simple like, I'm cutting back on my carbs, or I'm trying to lose some weight, or I just don't feel like that today, right? And there's things you can do. Like some people in family really just want to show you love with food, and they really do want to communicate love to you in that way. And so if grandma is trying to give you the mashed potatoes, you can say, "Oh, these are so good. I've always loved these, but what I'd really love is I just love your Brussels sprouts. Could I have some more of your Brussels sprouts?" And that allows grandma to love you with food in a different way. And then like Beth was saying, if you can get the whole people around, all that person's support network, true support network, and educate them, I find they can be wonderfully supportive. And you might be very surprised how much the people in your world are going to encourage you. But if you don't have people like that in your world, that's okay. You can still do the ketogenic diet.
I'll add to that I think one of the behavior modifications that I've worked with that I have felt is successful is actually going through a scenario with the teenager and say, okay, we're at your after game party and they have hot dogs, pizza, cookies, and Gatorade. What are you going to do? And talk this out. And if they don't pick hot dogs, I'm going to say, okay, the hot dog really is the only thing you can have there. And so what I want you to think about when you get into that situation is take a moment, say to yourself, I'm going to scan the table and identify at least one food that I think I can have. If there's nothing that I can have, I'm leaving. And I have had people do this because they just can't stand to be there while everyone is filling their faces and have to say, I'm just not hungry, I'm just not hungry, and basically lie. So if they can have that one food, that's what they're going to have. Um, but my point is to talk about it and to practice it in a therapy session is just going to make it much more comfortable when that teen gets to the session. And this is mostly boys because the girls don't seem to be worried about this. The girls are like, this is cool, this is all the girls are on a diet, right? So most of the girls I find are pretty easy with making a transition like this and don't really, have a big concern with either explaining or not explaining to anybody. It seems to be the teenage boys that I have run across that really struggle.
Chris, you wanted to add something?
Yeah, the thing I would add is especially when people are keto adapting in the first few months, their cravings often have not gone away. And so if they're out in a social situation and they see food that they used to love or still love and still crave, more often than not, it's just a high risk situation, let's put it that way. And so two pieces of advice that I often give people are number one, you're actually just letting them know this is a whole mind shift of the reason you're going to this event is to be around your friends. It is not about the food at all. And in the past, you probably thought you were going to this event because it's a pizza party and you're gonna have pizza and the side benefit is your friends. I need you to think about it. The only reason you're going is because of your friends and the food is optional. And so a lot of times I'll encourage people to eat before they go to the event. Go ahead and eat your ketogenic meal before you go. And then you're going to have a small appetizer or something else and a seltzer or whatever to make it look like you're participating, but you're not going to be hungry. And I actually want them to not be hungry, because if they're hungry and they're around friends and they have this pressure, whether it's real pressure or perceived pressure, there's just such a high risk that they're gonna give in and start eating. And then the other piece of advice that I often give, because sometimes they're like, well, I'm not home. I'm going right from the game to the event or right from school to this thing. And then I just encourage people to pack their own food. So like take along a little portable thing, pack something keto. If you don't want to eat it in front of everyone else, eat it in your car on the way or whatever. So again, just kind of survival skills of this is a really important part of your treatment. It has the potential to change your life, or it's already changing your life. Let's respect that and acknowledge that, and let's help you cope with how challenging this is going to be.
Absolutely. And I would underscore one of the things that we tell parents all the time is take a page out of the playbook that parents of children with severe food allergies have, which is they don't ever show up to a event with food without a little lunchbox filled with equivalent snacks that their child can have that will be safe for them. And when we're talking about mental health stability, we're still talking about safety. Lori, did you want to add something?
Um, I think I just wanted to talk about being the cool mom. So this is for, not me, this is for the moms that are listening. Because I just think it's such an important step for a mom to be able to sort of dial in to what their teenager is going through and figuring out, gee, if I were a cool mom, I'd probably make cool food and invite his friends over so that they have cool food that's not necessarily keto food or keto looking food. And so that your house becomes ultimately a place where your son now wants to invite his friends, where your daughter now wants to bring her friends, where in fact it becomes easy so that then if your child takes some of that food to their next gathering, they've got it. And you're the mom who's sort of introducing cool, delicious stuff to their friends just as part of what you do. So I think it's just so wonderful to have that be the attitude instead of the attitude being, oh no, like let me get you ready before you go. It's kind of like, let me make it really successful. Let's invite everybody here and have them eat what you're eating because I'm going to make it look good. I'm going to make it taste good. They're going to love it. And it's going to be easier then to share it.
So this leads into a really important question that a lot of people have around culture and food. You know, a lot of what we talk about when we're talking about ketogenic therapy, what's commonly described in the literature, is really a lot of Western food staples, meat, dairy, eggs, low carb vegetables. But there are a lot of cultures around the world that are the staples of their diets are rice and beans and root vegetables and corn or breads. So how do we as clinicians and providers of this therapy help when we are working with folks who come from cultures where these foods are really important to how they eat, and taking away the beans isn't just about reducing carbohydrates. It feels like we're taking part of the culture. Anyone should feel free to jump in and answer this.
I'll
Yeah,
start.
yeah.
Oh,
Go ahead, Beth.
one of the things that I have learned to talk about with people is the huge culture change of this diet. And one of the things that I have used as an analogy is like it's like changing your religion. Can you imagine changing your religion? You wouldn't think about this, on any given day unless there was really good reason to do that. It's a big shift. But why are you doing this? It's something that really just needs to be talked about in terms of the treatment. It is a metabolic therapy, and yes, it's food. And food is very personal and it's really comforting and it's something we look forward to every day, each and every day. And how can we find other things in our life to change to feel that good about than the food in the kitchen. So it's got to be just, Chris, you really led the way with this, is that it's got to be a discussion that you have, that you bring out from people their willingness to find alternatives to that comfort. Um, and I come back to this several times when I start working with people, because usually people are really excited for 2 weeks. And then all of a sudden they realize, oh my goodness, what about Taco Tuesday? And what about birthdays and all these other things that they didn't realize brought so much joy to the family, and all of our holidays, right? And culture, right? So it's got to be talked about several times, I think, in order to be really effective.
Nicole, you wanted to add to that?
Yeah, so I get to do consultation with people all over the world. And diets in which, or traditional diets, that include rice, or I work with people in the Middle East. There's a wonderful lady I work with in Korea, and they modify, and happily modify. I'm kind of in the position where when people seek me out, they're ready to go and they want to figure it out. And so that's really nice. And then I would also say, there's really a lot of great blogs. You pick a culture, there's not all of them, but many of them. You pick a culture and you do a Google search. Someone's starting a blog about how to do keto in Greece, or how to do keto in some other country. And so there's, there's a lot of really good resources and ideas for that. And then I remember hearing a talk by a dietitian in the UK, where the dietitians really understand how to modify the diet really well for different cultures, I think, from around the world. And so there's really brilliant dietitians that do that. And then from a psychotherapy standpoint, sometimes people will come to us and say, this is my traditional diet, this is my traditional diet. And one of the reframes that I offer to them to think about is that truly your traditional diet? Or was that a post-colonial diet that was adopted later? How far do you need to go back to figure out what your traditional diet is for you? And that's actually been a very successful reframe for many individuals, from many different cultures, and that's been very helpful. So people do it, they adapt, they learn how to do a taco bowl on Taco Tuesday, they learn they learn what to replace the rice with, or they know what to add in addition to, and people are highly motivated to get better, because how they are feeling is so unsustainable. So again, I would suggest that any practitioner that's like, oh, this person is from this country, they're not going to be able to do this. Don't put that on them. That's your bias. That's your idea about what they're capable of. If they're coming to you wanting to try this therapy, you support them in finding a way to make it happen.
I want to share something that came in through the chat from another one of our colleagues in the world of metabolic health, Denise Potter. She's the founder of Advanced Ketogenic Therapies, and she said, I love what Lori said. I have a mom that sent such beautiful meals to school that the other kids wanted what her child was eating. She finally wrote a cookbook that is going to be translated into English because it is written in Croatian. So certainly evidence that anyone can do this. Shabani, you wanted to say something.
Yeah, I was just going to add to what Nicole and Beth said, that reframing it also in the aspect of it, not a diet, but a therapy, and letting that sink in, that it's a medical therapy for them and their illness. So in the same way, if they were diagnosed with another condition that they had to make changes for, and if it was a food intolerance or an allergy, you have to make those changes. I think that uh, setting that frame, but also getting buy-in from their family or a caregiver or support person can be really helpful, just in that context, especially if culturally there's maybe more of an emphasis on carbohydrates. But I also agree with what has been said, that just globally, people reach out and people do things in other cultural contexts and figure out a way to make it work. So I think there's a lot of room for that.
And so when we're talking about access to this therapy, a question that comes up a lot is around finances. Ketogenic therapy, food plans can be perceived as being expensive. There's a perception that you have to get these high quality, expensive meats in order to be keto compliant. And access to food, especially in food deserts in certain areas of the US and elsewhere, makes access and really being able to choose foods challenging. So how do those of you who do this clinically in practice, how do you address food costs with your patients who are doing ketogenic therapy? Go ahead, Nicole. Yeah.
So I have a nonprofit that offers ketogenic education and support to people who are on government disability or show evidence of low income. I have lots of individuals who are on EBT and different types of government assistance who are on very, very difficult budgets for buying food. And they actually find a lot of really creative and doable ways. They get low carb vegetables from the dollar store in the frozen section. They plan their meats out, and they find good quality fats. So from different grocery outlet stores, and they watch for sales, and it's quite doable. And it's not just in my population that I work with. There's also health coaching, ketogenic health coaching in the Bronx, working with some of the most poorest neighborhoods in which I think it's Ona Health, in which they're helping people also. And so it actually is quite doable. And I actually have people saying that are on low income saying that they have saved money on their grocery bill because, a lot of highly processed foods are quite expensive off the shelf and they don't necessarily offer the same nutrient density. And people are saying that, they actually end up kind of eating less, but it's not in a bad way because they feel satiated and they feel like they're getting their nutrients, and it just shifts everything. And there's also a published case study, I believe by Newest, that where there was an individual with schizophrenia that was living in a van with a very difficult budget. And I have people in my online program who are living in vans and having difficulty, not with just, they're having difficulty with housing, and they have food scarcity, and they're doing it. And I'm telling you, people will do anything to feel better than how they are currently feeling. They are highly motivated and it is doable. So again, don't assume that someone won't be able to do the diet just merely because of finances. They may actually be able to accomplish it. Okay.
I just wanted to say, I completely agree with Nicole. Um, I guess in practice, outside of research, has been really important to me. So I've done it and I continue to do it, but access to care is equally important, to be able to translate the science to, to out there, and scale it. So I did found a company called Metabolic Psychiatry Labs, and we take Medicaid patients, we take Medicare patients, we take insurance, and folks do, there are folks in vans who are on a ketogenic therapy, and we figure out a way to make it work, and it can be done on a budget.
So we are just at the end of our time, and I want to honor the contribution of time, talent, and expertise that our panelists have brought. But I have one last question. How do you measure success we've talked a lot today about things like ketone levels. There are, blood marker levels like insulin, fasting glucose that we can use to measure success, symptom remission, uh, social stability, the ability to maintain long term. So for each one of you, when you're thinking about your practice, your research, the work that you do, what is the thing that you use most to measure the success of ketogenic therapy? And again, I'm just going to go around my screen. So Chris, I'm going to put you on the hot seat first.
Reducing someone's suffering or improving their ability to function and thrive in life.
Matt?
Yeah, I think it's all about functioning, the ability to show up in their life, to work, to have relationships, to enjoy the things that they're meaningful to them. That's the most important thing for any therapy, let alone ketogenic therapy.
Lori?
I look for flourishing, resilience, and the development of self-compassion as people move forward.
Shibani?
I'd say quality of life. I think it includes a lot of those things that were said. And I'm a clinician at heart over either an entrepreneur or a researcher. So that's the thing I care about the most. And that's why it's the primary outcome for the randomized control trial that we're starting.
Beth?
I think the words that I live to hear are, I never knew I could feel this good.
Nicole?
Yeah, it's the reduction, like Chris said, I resonated with the way he said it most, the reduction of suffering and an improvement in quality of life. Even if it is not the spectacular, miraculous recovery that many people experience, which is wonderful, there's also individuals where that doesn't happen, and that's okay. That's okay because their quality of life has improved, their suffering in some way has diminished, and that is a win.
Georgia?
Yeah, I mean, there are all kinds of scales that we can all use. We use them in research, we use them even in clinical practice, but they don't capture what it is that everyone wants something different for themselves. And so I always ask, what are you hoping to get out of this? And so what I live for is having them be able to accomplish their own goals, whatever those are. And I mean, I guess a word that I would use is empowerment. I love to see people feeling empowered and feeling that they didn't realize that there was something that they could do that could change their brain chemistry, their physiology without medication or with less medication. I love seeing people experience that, and that the joy and the empowerment that they feel when they feel that they've accomplished something that I couldn't accomplish for them.